So good afternoon. Hope everybody has had a lunch, good lunch, and I hope people are not sleeping now. So MIGS has become part and parcel of all the glaucoma surgeons, and for us, we wanted this session talks about what is the update and going back into the basics also, trying to understand the concept of MIGS in today's era while not forgetting what is the anatomy, how do we assess, and what exactly are we striving at when we go on with the expanding armamentarium that comes under the one bracket called MIGS, and what should we keep in mind when we are doing this. So with this I will start. We have a lot of speakers here, very eminent, very adept at different types of MIGS procedures. Each one of us having the doubt that which MIGS works best, what is going to be giving a good outcome, and what should we keep in mind when we are starting off. So this session tries to uncover some of the basic concepts as well as touching the updates on that. Devendra? You are the first speaker. Okay. You can introduce. I'll just go on.
So we have our first speaker, none other than Dr. Aparna Rao. She is a glaucoma consultant at LV Prasad, and she's going to talk on anatomy and physiology of outflow pathway.
So when we talk of MIGS, before we even start, it's important for us to refresh and revisit the trabecular meshwork anatomy, because whatever we understand of the trabecular meshwork anatomy is from old studies from Duke Elder or other textbooks, what are from enucleated globes. So what is the current update? What is the old anatomy? The old anatomy, traditionally, we know that the trabecular meshwork contains three parts, that is namely the one which is closest to the Schlemm's canal, this big lumen here is the Schlemm's canal. The one which is closest to that is your juxtacanalicular tissue. The one which is after that is a corneoscleral tissue. These two they differ not in terms of morphology, but in the intertrabecular spaces. You can see that here the juxtacanalicular tissue is very tightly bound, while the CSM you have wide intratrabecular spaces. And the uveal meshwork is seen as extensions of the CSM as the trabecular meshwork keeps moving towards the ciliary process or close to the iris. So we traditionally know this as parts of the trabecular meshwork in textbooks, what we read. So this is what we get in histopathological specimens. If we get external trabeculectomy, most of the tissue sample will have parts of the sclera and the cornea, and the trabecular meshwork actually will be a very small bit, or in enucleated globes. This is how we see the three layers. But do we understand the trabecular meshwork ultrastructure differently? So the question that arises is, if these are the three parts, all that we know is the juxtacanalicular tissue is a region of most resistance. But what do we understand about the role of then the CSM, and what's the role of the uveal meshwork? This question always pops up as to what those tissues are doing. Why has nature given these three filters kind of a thing in the eye? What is their role? And are these three regions affected differently in different types of glaucoma? Logically, theoretically, yes, they should be affected differently, but we don't know. So when we try to do scanning electron microscopy of trabecular meshwork samples taken out, this is pure trabecular meshwork samples, not the ones which contain the cornea and the sclera. When we do that, this is a patient of steroid-induced glaucoma. Now, in steroid-induced glaucoma, we know that there are steroid polymers or glycosaminoglycan deposits which actually block the trabecular meshwork. That's what we know as pathogenesis. But what exactly happens at the trabecular meshwork level? We don't know. So when we do a scanning electron microscopy, we find that there are very bright, if I might say, electron-dense deposits deposited all over the juxtacanalicular and the corneoscleral meshwork, but absent in the uveal meshwork. You can see these bright deposits here which actually light up, and these are mostly only on the surface of the trabecular meshwork beams. So if we understand and recall, these electron-dense deposits might be the glycosaminoglycans, and we know that the steroid receptors are on the surface. So what do these deposits represent? We still do not know, but what is important for us to understand is that these deposits are widespreadly found only in the JXT and the corneoscleral. So why is it not present in the uveal meshwork is still a question. Similarly, now in controls, how does the trabecular meshwork look like if we take a control sample, only the trabecular meshwork, how does it look like? So if you see here on scanning electron microscopy, in controls, the trabecular meshwork beams are rounded and they are broad. Compare the top panel, which are in controls, to the below pictures where the trabecular meshwork beams have now become almost thread-like. They become thin and broadened, flattened. They lose their round architecture, and some of them may be thinned out so much that they appear very slender and fiber-like, thread-like, as you can see in pictures. But most importantly, again, what is most important, even if you take it from a moderate to severe POAG, this is a sample from POAG, these are samples from primary open angle glaucoma, both on histology as well as scanning electron microscopy, it is only the parts of your corneoscleral meshwork which are affected more, where I'm referring to the thinning of the trabecular meshwork beams. But in the juxtacanalicular region, somewhere the rounding off or the thinning is not so much prominent, which is contrary to what we understand as the juxtacanalicular playing the major role in resistance. So we expect that the majority of the findings should be there in that region. But if you do a scanning electron microscopy, you find most of the changes prominently only in the CSM. So this again tells you that the three regions are affected differently in different types of glaucoma. This was an interesting study wherein now we know that the trabecular meshwork beams pump aqueous into the Schlemm's canal. But if we want to understand how does it do so, all the trabecular meshwork beams, if you liken that to a heart muscle, do all the collagen beams function as a syncytium, contracting together, or some parts contract more than the others? And how does the fluid go in a unidirectional position? Why not when the compression happens, the fluid goes out in other directions? How is that unidirectional flow maintained? So this was a very interesting paper in 2021, which showed that, there are channels or processes that come in between the trabecular meshwork beams, kind of, you can say, projections that come up from the trabecular meshwork beams. Only when there is contraction, that actually now can be seen when the TM is contracting. So possibly these processes, this is the diagrammatic representation. These are compressible chambers and valves, as they call it. Now, presence of these valves ensures the unidirectional flow of aqueous towards the Schlemm's canal. Remember, your Schlemm's canal is 360 degree, so it's really a wonder as to in the superior quadrants or a nasal or a temporal, how does the unidirectional flow is maintained? How is that maintained? Because it has to act against gravity. So presence of these valves is actually possibly helping the unidirectional flow towards the Schlemm's canal, and is an active procedure if we are to believe that these valves exist. But these were in porcine eyes. Now we wanted to see whether it can be present in the scanning electron microscope also, obtained from patients. Now you see a distinct distinction between the two zones here. You can actually see a not so clear but a subtle line of demarcation between your juxtacanalicular and your corneoscleral and the other parts of the meshwork. You can see that here the meshwork is really compact, whereas here the spaces seem to be, this is in low magnification, but just to show that the spaces are more in the corneoscleral meshwork. So we could see the demarcation, but then this is now highlighted here. But what was more important are the presence of these so-called valves or processes were seen both in the juxtacanalicular and the corneoscleral processes. You can see here these are processes that come up in between the beams. We are not sure as to what part of the beams it is coming from, but you can see that some portions you have actually captured that when sectioning that. These are processes that are there in between the trabecular meshwork beams, and it is not present at all the regions. So some of the beams, these processes are present, some of these, they are absent, but they are present more in the juxtacanalicular as opposed to your corneoscleral. So these valves or so-called processes are possibly the reason why how the eye maintains a unidirectional flow of aqueous towards the Schlemm's canal. This is in high magnification of the same. And also when you try to do transmission electron microscopy, we all understand that glaucoma as such is an autoimmune process. There is oxidative stress, inflammatory markers are supposed to be increased. So we wanted to see actually, is that proved in the trabecular meshwork? if we want to see what is the level of stress markers. So we see a lot of autophagosomes and lysosomal vesicles on transmission electron microscopy in different regions. What you see here as crisscross striations in different regions are the collagen bundles, and the orientation differ as to where and how those bundles have been sectioned when you're sectioning the whole sample. But there are a lot of vesicles even in a normal patient. So how these vesicles and what are these vesicles doing in a normal patient versus a glaucoma patient is something that we have to really see. The most important thing about anatomy when we understand, even when we do an MIGS with relevant to that, is what is the flow that happens when we rip off the trabecular meshwork, or when we are incising the trabecular meshwork. What are we doing? Or we are passing a low flow resistance by introducing a stent there. You are overcoming this resistance that is offered by the trabecular meshwork. Traditionally, we understand that there are different veins whereby from the collector channels, after the trabecular meshwork pumps it towards the Schlemm's canal, it's collected by the collector channels and then sent into different venous plexus, superficial as well as deep. From there, it goes into the systemic circulation. But what is more important is the aqueous veins. Now, aqueous veins have been described, but I don't think so any of the imaging modalities have actually shown the presence of aqueous veins. We are yet to determine that, because these are big channels that actually, if we are able to image and we are able to do a surgery around where the aqueous veins is, your IOP reduction will be very quick and it will be massive. But we don't know how to image that. But what is more important when we do an MIGS, be it an incisional, be it an excisional, or be it a stent, is that you are now overcoming the resistance that is offered by the trabecular meshwork to aqueous outflow, albeit over a specified quadrant or number of quadrants. But what happens to the collector channels distal to that, we don't know. So most of the IOP spikes or the failure that we see after MIGS is possibly because we understand there is something that is regulating the resistance, and that is directing the flow of aqueous right from the collector channels towards the veins. So if we are taking one part of the resistance out and that becomes a low resistance pathway, obviously these collector channel flow and the flow in the venous plexuses are not going to be the same. Possibly the body will now try to adapt and reduce the blood flow, and that is what is described or presumed, that the collector channels in those regions actually collapse after some time because the resistance has gone. So actually, your MIGS might be doing more harm than benefiting in some patients. Though this is not proven, we don't know. So we always have to remember this, that we try to think that we are doing something good like an MIGS. Yes, we have proven IOP benefits, but in the long run, we have to see what actually happens to the collector channels over long term. Do they close? And what happens to the episcleral venous plexuses? What happens to the flow in that quadrant? Aqueous angiography can actually show you that over long term. And the most important points to ponder is what happens after we do an MIGS. You are cutting, you're excising, you're incising, and when you put a suture under the trabecular meshwork, remember you're gouging under the trabecular meshwork. It's like going under the water in a beach and taking some part of your sand and then the water. Obviously, that area is not going to be the same. It will be filled up. So what is it filled up? It is filled up with fibrotic tissue. So these healing responses that occur after you do an incisional or excisional procedure is equally important to be imaged on ASOCT or UBM and try to correlate it with your clinical findings. We don't know exactly where does this healing response come from. You see hypertrophic scars. You see sometimes the ridge to be closed by a fibrotic tissue, but where is that fibrotic tissue coming from? Is it from the scleral fibroblast? Is it coming from somewhere else? We don't know. Further, stents and MIGS, like I said, what are the causes of failure? Is it closure of the collector channels, or is it some other reason like fibrosis over that region? We just do not know. And where should we incise? If we understand that the JCT is the site of maximum resistance, why are we leaving or incising most of our incisions at the junction of your anterior and posterior trabecular meshwork? Because if we understand the junction of the anterior and posterior TM is where the stem cell niche is presumed to be. So by incising there, you're actually causing inflammation there and you're leaving the juxtacanalicular tissue. you are only excising part or incising only part of the corneoscleral meshwork while the GXT is still there. So these are things that we have to really matter, whether if you make an anterior incision close to the Schwalbe's line, remove the GXT also, does it really matter as far as the IOP control is concerned? These are points to ponder. As far as the anatomy is concerned, we would like to go into the second session. Thank you.
Thank you, madam. Very informative, excellent lecture. Now, our next speaker is Dr. Anil Mandal. Anil Mandal, sir, don't need any introduction. Do somebody talk about the congenital glaucoma? The other student is Dr. Anil Mandal. So he is one of the best surgeon for congenital glaucoma and is very senior leader and expert surgeon at LVPI. Over to you, sir.
Thank you. Can you present the video? Although this is a session of MIGS, I am presenting a surgical video on standard trabeculectomy without any antimetabolite. Can you present the video? This is the standard, gold standard technique. MIGS must be compared with standard glaucoma filtering surgery, that is trabeculectomy, because this is the gold standard against which any new procedure must be evaluated. What we are seeing here is the superior rectus traction suture is given. One can give corneal traction suture, and the eye surface should be washed thoroughly before we really incise the conjunctiva and the subsequent steps. Here I am showing limbus-based conjunctival flap. Tenons and conjunctiva is dissected in a single layer, and the dissection is carried out on each side. An incision will be given to incise the conjunctivo-tenon layer on each side of the entry point. The tenon's capsule is being dissected, and then the other side incision is given. The way I used to do the incision is the way it is seen here, about 6.5 millimeter from the limbus, just in front of the superior rectus insertion. Superficial cautery is done to really cauterize the episcleral blood vessels. Now, I give standard incision about half thickness scleral incision in a triangular fashion, and this is with the help of 11 number BP blade. With the help of limb forceps and 15 number BP blade, I am dissecting the sclera. Thickness will be 1/3 to half thickness sclera. In pediatric glaucoma, we used to make it relatively thicker superficial flap. In adult, it can be 1/3 thickness. The dissection is carried out anteriorly towards the limbus and is carried out just about 0.5 millimeter in front of the anteriorly into the corneal lamellae. Now, the anatomy of the limbal region should be carefully identified. With the help of a traction suture with tenonylon, the assistant used to put the finger over the retracted suture, and then 2 radial incisions are given just to delineate the area of trabecular meshwork or the subscleral tissue you want to remove, without entering the anterior chamber. This is just to delineate the area which you want to include. And the posterior incision will also be given, as you are seeing here, again superficial incision just to delineate the area of subscleral tissue you want to remove. Then a very pointed entry just to make sure that the anterior chamber is entered, and you can see the blade has been reversed so that it just inside the superficial wall, and then with the help of micro seizure, venous seizure, 2 by 2 or 3 by 2 millimeter limbal tissue is excised. You can see here the block is made and about to be removed just like that. One can use punch or the way the surgeon prefers, and you can see I iridectomy should be done with base which is equal to or even little larger than the deeper block removed. In higher magnification, it will be showing here once again the way orientation should be, that the base of the iridectomy opening is wider than the apex. You can see the ocular pulse here. At this point of time, under higher magnification, you can see 2-3 ciliary process. And that's the end of trabeculectomy part and iridectomy part. And then the superficial scleral flap will be sutured back. The tenonylon suture. I used to do 3 sutures, one at the apex, one on each side of the triangular scleral flap sides. But because I do not believe in using mitomycin or 5-FU in primary surgery in all the cases, newly diagnosed case with moderate to severe degree of glaucoma, I did some experiment in my early years in the late 90s, and I felt that the good results can be obtained, intraocular pressure control can be obtained if we avoid side sutures. That is, one on each side suture can be avoided. One can argue that it can lead to overfiltration and shallow anterior chamber in the early postoperative period. Not really, because if you do the surgical technique, it is possible that chamber depth can be maintained even though there will be little shallowing, and as and when you are completing the suturing, that is apical suture, the chamber starts deepening, and the tenonylon suture is trimmed, and the knot must be buried inside the sclera. That's the way it is shown here. You cannot afford to put not to bury the suture, because it will lead to perforation of the conjunctiva, and in the postoperative period it can give rise to a tract which will invite infection from the surface. Endophthalmitis or blebitis or bleb infection can happen. The conjunctivotenon layer is repositioned as you can see here happening, and a continuous suturing is done to close the conjunctival tenon layer closure. So this suture is aetovehicle suture with a tapered needle, round-bodied needle. It is preferable because cutting suture should not be used. It will lead to multiple points of leakage in the suturing area. Permanent knot is given there, 3 single throw suture, and then with the help of a good needle holder, with your best control, suturing from one end to the other can be done with a continuous suture. And in the beginning you can do the suturing, say in the posterior inside out, then outside in the anterior it is inside out and then outside in. In the posterior it is inside out and then again outside in. That's the way entire length of the conjunctivotenon layer can be threaded. It requires little practice. It's like a closure of the subcuticular stitch we used to do for skin. And the entire suture, if in the beginning phase of surgery somebody can do in steps, no problem. But meticulous suturing should be done so that there should not be any gaping, and the suturing will end in watertight closure. And at the end, finally, one permanent knot will be given. You can see here, I am including the finer or the final stage of threading of the conjunctivotenon layer, and it will be closed. I do not use mitomycin, as I told you, in the most of the surgery. Even now, the surgery which you are seeing here was performed in the year 2001. This is about more than 24 years ago surgery. I still do this surgery in the same way. This is the surgery I saw my professor N.N. Sood used to do, and I learned from him, and inspection should be done that the entire length of the conjunctivotenon layer incision is positioned very well, and a permanent knot will be given in the other side. You can see here. Now this is the end. You have seen I have not given any paracentesis opening. I have not done any I'll say flow of fluid, ringer lactate or balanced salt solution in the anterior chamber. I personally believe minimal invasion or minimal manipulation, because in Indian eyes pigmentation, iris pigmentation is such, the moment you will try to see the efficacy of the ostium, how it is filtering intraoperatively, will lead to release of pigments, etc., which will be causing more inflammation in the early postoperative period. The least manipulation, except the iridectomy and the final stage of trabeculectomy, I have not entered into the anterior chamber, and this is the standard appearance at the end of surgery. Now the question is, in difficult situations, this is an isolated trabeculectomy. If I do combined trabeculotomy and combined trabeculectomy with cataract extraction, I do fornix-based incision, there limbus-based causes more manipulation and more problem. This is the end of the technique. At the end of the surgery, superior rectus suture is released, removed, and inspection is done so that we know the closure is good. Somebody may put a fluorescein drop, which I really do not prefer to spoil the surface by the fluorescein pigmentation. No paracentesis, no saline injection into the anterior chamber. I personally believe, stop here. I personally believe this is the way to go. If you are doing limbus-based flap and one can do little modification the way somebody wants, that's okay. This is the standard way I do, and I'm happy with my results. The only technique I have changed, suturing technique of the scleral flap from 3 suture to 1 suture. That's it. Thank you.
Thank you, sir. Very excellent to meet you and excellent talk. Our next speaker, Dr. Appada from HC, is speaking on outflow assessment in intraoperative OCT. Over to you.
So this again I thought is important, because when we do an MIGS, there is no way of assessing whether what we are doing is actually going to be effective, and no way of predicting whether this patient is going to need medicines, whether it's going to go into complete success, qualified success, or whether this case is going to fail. So I'll skip the slides, because now this question is much more valid, because there are a lot of combination MIGS procedures that are being offered. Let's say eye stent with eye device, or combinational GAT with something else, or KDB with something else. So the both incisional excisional procedures or stents with other procedures are being combined. The question that we have to ask is there a way to assess whether whatever minimally invasive surgeries we are doing, whether it is maximally effective or not, or even if optimally effective? So the question is, how do we assess the outflow pathway intraoperatively? We can do that with handheld AIOS or OCT angiography. How do we assess the vascular plexus? I showed the slides of the drainage of aqueous into from the episcleral veins. So how do we assess that? We can use OCT angio. We can't use FFA in India. I think we don't have microscope with the filters to do intraop FFAs. Intraoperatively, we only have OCT angiography, where we can see, or we can use intraoperative AIOS to find out what level are we incising and what is happening. But a more simple technique we all know is blanching, or what we call as the episcleral wave. So episcleral wave is nothing but, suppose you have excised, or I excise the trabecular meshwork tissue from inside. So if I have excised this clock hour, I just go there and inject saline, and you can see that the whole of the sclera has become white. So the episcleral vessels have blanched out. This is called the blanching effect. But I went one step further to see whether I can see what veins are draining into that area where I have excised the TM. So you can see now I inject trypan blue, the normal trypan blue that we use for staining the capsule. When we do that under the air bubble, you can see now such a large area of blanching, almost 3 clock hours. But what lights up initially is only one large superficial episcleral vein. So it's hard to believe that such a large area is being drained. One vein is actually draining one large area. And with time, as we keep injecting, the beauty now is as if some of the collector channels or veins have some valves which open at a certain pressure. So if you keep injecting, now not only this veins, but you can see now the rest of the deeper scleral plexuses also light up with the dye. So the deeper plexuses possibly operate at a higher pressure, whereas the superficial veins operate at a lower pressure. We don't know, but intraoperatively I tried doing this. We studied this in 167 eyes, both blanching as well as a trypan blue. What we found out was there were 4 patterns which is already described by Ike Ahmed. We have those 4 patterns. We found 4 patterns. One is the superficial vein staining, one is the deep vein staining. The other areas are a diffuse kind of a bluish hue. You won't find any one vein draining it, but you will just find a bluish hue, which means that in that eye, you only have very deep plexuses draining it. You don't have any superficial vein, which is very difficult to think of. Then how is the deep veins draining it to the systemic circulation? We don't know. And the other type is a reticular pattern, which means that it's a spider web kind of small vessels which are there at the limbus, but you don't have any vein lighting up further. So you really don't know whether those few vessels at the limbus are draining such a large area. We don't know. So some videos, some people might have seen these videos, what I refer to as blanching, you can see here. You can see the whitening now as I keep injecting, and the blanching also happens in one quadrant at some time, and if you keep injecting, the blanching happens in a wider area. So that's simple blanching that you can do to assess if whatever you have done actually has helped aqueous outflow through that region. Now the procedure about trypan blue. Now this is the area that I have caused a blanching. You can see the whitening, but now see the kind of veins that are there. There is 2 deep veins. The blanching happens here. There are 3 veins here, one here, and one here. And there are some deeper veins which are staining, all in that same area. But it's not so simple because the blanching is seen and the trypan blue staining is in the same area. Does it happen in all the areas? No, it does not. You can see here when we inject, now the blanching happens from here to here almost. But see what happens when you so now you can see that there is a very diffuse hue here, but then here there is one vein, superficial vein lighting up. So even in different regions, the kind of venous drainage that happens in each different sectors or quadrants is completely different. It's not simple. The variations in each individual to individual are so huge that you cannot generalize to come to an algorithm. What we could find out that if you don't have a blanching or a trypan blue staining in less than 3 quadrants, if you see more than 2 quadrants or 3 quadrants of staining and trypan blue, you know that that patient may be free of medications. But if you see it in less than that, possibly this patient is going to require medications or going to fail. That's all you can have. So this is the patient where you saw blanching happening, but then the trypan blue happening quite far away from the area of blanching. This also happens. So we don't know the reasons. So the quadrants of blanching do not always correlate to the trypan blue staining quadrants, which may be very different, and does not always correlate to the IOP outcomes. We have eyes where the trypan blue staining happened in all the quadrants, but then the IOP rose up to 22, 21, and we end up giving medications. The anatomical variations, both in the superficial and deep plexus, are huge. From individual to individual, and these probably account for the lack of a generalized algorithm. We yet do not know how to identify the aqueous veins. If we know that, then possibly we can maximally optimize our site of MIGS. The Schlem's canal dynamics, like I said, we do not know what happens. We are just taking off the resistance by taking off the trabecular meshwork. So what happens to the collector channels? What happens to the pressure outside that? Obviously the body and the episcleral venous pressure is higher. So what happens to that? The body is not going to keep quiet. There are variations that are seen. On ASOCT, you see scarring. That we do see on ASOCT. There are different types of scarring that you can see. You may see an open gutter like this, where you see that the gutter that you have created by excising the TM is still intact. There may be sub-incisional scarring, as you can see here, beneath the gutter. So the question here is, where exactly these fibroblast or healing response come from? If it is beneath the Schlemm's canal, it has to be from the sclera. So where exactly the fibroblasts are coming from? The other type of gutter is seen in, you can have mild, moderate or severe depending on how much is the hyperintensity. And in GAT, you can see this kind of a trench pattern of scarring, wherein not only you see subincisional scarring, but you also see that you can see the trabecular meshwork leaflet, but the scarring response has gone beyond that. So you don't know what has happened here. The other interesting possibility is if you have access, you can use the intraoperative OCT. You can actually incise at various steps as you're incising. Where exactly? Is it part of the trabecular meshwork that you're incising, or close to the Schlemm's canal that you're, small base line that you're excising? What is exactly happening? You can see the leaflet also once you've excised. And you can actually see, this was one patient where we actually saw something spurting out of the Schlemm's canal, which is nothing but blood and other efflux happening. But this requires a constant person or one or two persons to, when you're doing the surgery with your two hands, your focus and your tilt of the eye changes. So the OCT, there has to be two technicians or your fellows or residents who have to keep the focus constant on the region that is being imaged. So this is what I was speaking of, that you can see that as soon as you incise, there is an efflux that is happening. You see that in most of the eyes, but at the end, all's well, that's gone well. Aqueous angiography, yes, people are pursuing. You can actually see intraoperative as well as postoperative as to which collector channels new recruitment has happened in which area, but this is not widely available everywhere. So this is one option that you can choose if you have access to that. And this is something that's coming up in the future, which is called robotic visible light OCT. This actually visualizes the Schlemm's canal in different segments and then creates a 3D reconstruction of how the Schlemm's canal is in all those regions. So this is actually like seeing inside the eye as to after your procedure and before the procedure, what has happened to the Schlemm's canal. So this is something that's coming up. It's a doubt whether how much it will be available in India and when is it going to come. Thank you.
Thank you. Nice informative lecture. Now our next speaker is not other than Dr. Amit Porwal, and he is a scientific committee AIOS member, and he is a president of AIOS, and he is a prolific glaucoma surgeon, and he is speaking on how to master KDB and bank. Over to you, sir.
Thank you, Dr. Devendra and Dr. Aparna, for including me in this course. So we have different approaches for MIGS, and what I'm going to talk about the trabecular meshwork. So we have the subcontinental space also, we have the ciliary boundary and the supracortical space, but I'm going to talk about the trabecular meshwork. So increasing the aqueous outflow from the trabecular meshwork and Schlemm's canal by tissue removal by procedure called BANG or KDB. BANG stands for bent ab internode needle gonectomy. So basically, there is excision of the trabecular meshwork tissue. It bypasses the trabecular meshwork and forms a direct pathway to Schlemm's canal for 4 to 5 or more clock hours. How much you are incising depends on that. It can be performed combined with a cataract surgery or as a standalone procedure in phakic, aphakic or pseudophakic patients also. So before we start this procedure, before we master this procedure, what is the ideal candidate to master this? So the patient should have a cataract plus the following indications. That is, when the patient is having mild to moderate open angle glaucoma, when the goal is to decrease IOP by 20 to 30% or in mid-teens, or to reduce the number of anti-glaucoma medications. So always combine this procedure with phaco so as to have a detailed view of the angle. So initially, you should always start this procedure with a cataract surgery. What are the equipments that are needed? You basically need a surgical gonio lens, a cohesive viscoelastic substance, a 25 gauge needle if you are doing a BANG procedure, or a dual blade if you are using if you are doing the KDB procedure. So after phaco and IOL implantation, AC is filled with a high density viscoelastic substance. To get an in-face view of the nasal angle, the microscope is tilted towards you by 35 to 40 degree, and the patient's head is tilted away from you by 35 to 40 degree. Apply a cohesive visco over the cornea and place the Schwann-Jacob lens or the surgical gonio lens, whatever you have, to get an in-face image of the nasal angle. So after placing the surgical gonio lens, How you're going to do this is after every cataract surgery of yours, master gonioscopy first. This is very, very important. Always master gonioscopy, try to identify the structures. You can prepare a bang needle, take it near the trabecular meshwork, rotate it superiorly and inferiorly without touching the tissue so as to practice the wrist movements what is needed when you want to cut these tissues. Ideal gonio lens for beginners would be a hands-free one like the Oculus Ecoflex or the one which is by Sensatech. These are disposable gonio lenses available for a price of 4,000 to 5,000 rupees. You can practice them first, identify the structure, and then if you think your practice is increasing, you can buy the surgical gonio lens, which is autoclavable one, which is going to cost you around 50,000 rupees. So the central point of the nasal angle is penetrated with the tip of one of these instruments. Thereafter, it is advanced for 60 degree inferiorly or superiorly. So there are various degrees of goniectomy you can do. You can do at 120, 240 or 360 like a suture cat. But I'm going to talk about the 120 degree goniectomy because that gives the result at par with the other with the 240 or the 360 goniectomy. So the goal is to excise the pigmented part of the trabecular meshwork and expose the Schlemm's canal into the anterior chamber for 100 to 120 degree. A blood reflex at the ablation site indicates appropriate depth has reached. So coming to bang, why bang? Especially in our country, this is the cheapest mixed procedure available. All you need is a 1 rupee 25 gauge hypodermic needle. It's a 5/8 inches preferred and a needle holder to bend the tip. A goniotome is fashioned by bending the distal 1 millimeter of the needle towards the bevel by about 75 to 80 degree, and this can be used to perform the goniotomy for 120 degree using a gonio prism. So this is how you are going to prepare the needle. Just distal 1 millimeter you bend by 75 to 80 degree and make sure there are no other kinks. Now coming to the procedure, as I told you, you should always practice gonioscopy because if you don't know what you are visualizing, you don't know what you are cutting. So after the cataract surgery, the lens is placed after placing the cohesive visco. First, identify the structures in the low magnification and then increase the magnification and just excise the trabecular meshwork in one go. Repeated movements should be avoided because then there will be a scarring will be more. So in one go, just cut the trabecular meshwork. Reflex of blood, that means you are in the right plane. So 120 degree goniotomy is done. First start from the center point, go inferiorly, and then you can start superiorly and then come to the center point and finish the goniotomy of 120 degree. So this is another case, once again showing the procedure. So ideally, we should always use a cohesive, never use an HPMC, especially in the interface, because if you use HPMC, it gets just washed out, it flows down, and there can be blood. You should always make sure that the incision is more corneal and not limbal, because if it is limbal, then blood can come into the interface and it can obscure your view. So these are the few tips which you have to take care before you start the procedure so that your surgery becomes very smooth. So why bang? Because in this, the bevel and the lumen of the hypodermic needle, it forms two cutting edges. So it gives an effect of a double blade goniotome capable of excising the tissue and block. So same thing like what you have in KDB. So the dorsal portion of the bent needle acts as a guard. It prevents the incision of the posterior wall of the Schlemm's canal and helps in maintaining the plane of the incision. Coming to the curved dual blade, it is expensive than bang because bang is 1 rupee and curved dual blade is about 30,000 rupees. But still, it is a good instrument, but depends on how much your patient is going to afford. So it is a single-use disposable blade. There's a sharp tip that pierces the trabecular meshwork. There's a ramp which touches the trabecular meshwork, and again it has dual parallel blades, which creates a paired parallel incision of the trabecular meshwork. It has a rounded heel, tapered sides, and a smaller foot plate, which improvise the ease of use as well as the optimized fit within the canal. So this is the tip of the curved drill, the way it looks. I already described what it is and the different parts of the blade. So coming to the goniotomy, how do you practice? So these are demo eyes which are available in the trade. I mean, we have this course in the SSTC area also, and in the trade area, the person who's selling the curved dual blade, they have the demo eyes. You can find out from them from where to get the demo eyes, and you can practice this in your home itself. So basically, in this, the procedure looks very, very easy because the trabecular meshwork is nicely formed, it's heavily pigmented. So you feel that it's very easy to perform this surgery. That's in the demo eye. But in the human eye, it can't be so easy unless and until you don't know how to do an intraoperative gonioscopy. So this is a Carina lens. This is a left-handed Carina disposable lens. So this is mark and meet. There are different techniques of doing the goniotomy with the help of KDV. There are 3 different techniques they have described. But basic goal is to excise the trabecular meshwork with whatever technique it is there. You are comfortable, you should go ahead with doing that. So again, this is all surgeries I'm showing you after cataract surgery. We can do this procedure with the phakic eyes also. So this is a hands-free lens, Ecoflex. You just place it, mark the initial incision inferiorly, then go superiorly, This you can see this is hands-free. Just if you are not getting a clear view, just touch the lens with the finger, and you can visualize the structures properly. And this is the way the tubercular meshwork is exercised. Now there is another hook called we have a tenito hook to perform this goniotomy, and there is one more called the Lance micro hook. It is somewhat similar to the basically the tenito hook, but this is more economical than the tenito hook, and this is available for about $450 to $500. So in this, basically the same procedure, but this hook can be autoclaved, and you can use it multiple times, and it's a fine, nice mark. So I would place this hook somewhere between the 25 gauge needle goniotomy and the KDB. So the width of the basically goniotomy what you create is much more adequate, I felt, with this micro hook. So coming to the aqueous lymphatics post goniotomy, what Dr. Aparna was studying. So I'm just showing you. Once you have done the goniotomy, you can always inject trypan blue and see whether the dye is escaping the collector channels. You can see in this, as I'm injecting the dye, the collector aqueous veins are getting filled with the dye. And again, I've tried this in most of the cases. It is not necessary that every case you will have this picture. Sometimes you might have just only one prominent aqueous vein, as Dr. Aparna was saying. So this is a very good thing to understand that you have done the goniotomy properly. So coming to complications, you have hyphema, transient IOP elevation, which is the most common complication, that is hyphema. Peripheral enterocytic postoperative inflammation and hypotonia are very rare, nothing to worry much. So Bang and KDB can be mastered only if one is well versed in identifying the angle structures with intraoperative gonioscopy. So always practice first intraoperative gonioscopy after every cataract surgery before you attempt any of these goniotomy procedures. Thank you.
Thank you, Dr. Amit. Thank you, Dr. Amit. Now we'll move on to the most important person, Dr. Ganesh Raman. I don't think he needs an introduction. If I can describe, he's a Rajnikant of MIGS. He's our Talaiva for MIGS. So which means that he is a hero for MIGS. All the MIGS procedures he can do very well. So, Dr. Ganesh.
Thank you, madam, for the introduction. Of course, MIGS has taken the world of glaucoma India by storm. Can I have the slides here or there? There, huh? So what it has helped us to do is offer our services in very challenging situations. So I'll go through some of the challenging situations where invariably we would have done a conventional procedure, but because we know MIGS, we've been able to a large extent, help our patients. So this is a patient who is a 54-year-old female patient who's got primary angle closure glaucoma. You can see the PI. And she has been suffering from rheumatoid arthritis and SLE also, and some other collagen vascular disease, and she's got scleral thinning in all quadrants. And that is how her sclera looks like. So you can see the sclera on the left side, so it looks always bluish, very bluish, and she's got a visual acuity of 624 in the right eye, 612 in the left eye. IOP when presentation on 3 medications, 36 and 32. And fortunately, after the PI, the angles were pretty opened up. So you would always think that, okay, if it's 32, why don't we just give a shot of mannitol and do a cataract extraction and then get away with it. Hopefully that should solve the problem. But since we knew our mixed procedure, we went ahead and did this is how the sclera looks. This is the right eye and the left eye. And these are all the options which are present for us. You could even think of putting an eye stent when the angles opened up. And these are all the options which exist. But what we did was we did a GAT for her, phaco GAT. So we did a phaco GAT using a 6-0 proline suture, and she had good response to treatment at 1 month. And then we offered the same thing to the left eye as well. And you can see that's a very clear cornea, and PI was patent, IOL in position, chamber deepened. And the end result was she had a IOP of about IOP of 15 millimeters in right eye, 13 in left eye, 6/6 vision. And she had a IOP reduction about 21 millimeters in the right eye and 19 millimeters in the left eye. So we were able to salvage her vision, intraocular pressure, and her lifestyle to a large extent, because now she doesn't need any medication after the procedure. So rationale for excisional goniotomy in angle closure, we've seen all the experimental studies show that the nasal angles filter well, but to a large extent the temporal also has good amount of filtration. So the idea of doing procedures like Tanito, which Dr. Devendra is going to speak about, and the GAT is that you can recruit the temporal channels as well, because they also tend to filter better. Somehow we are not able to visualize that, and because we always focus on the nasal, that's what been in the literature, but you could always recruit temporal channels for aqueous humor outflow. So silicone oil glaucoma is again an issue. So this patient had, as you can see, radial keratotomies, and he had retinal detachment. Silicone oil was injected, and then he was settled, RD was settled. Then he was left with a visual acuity of, with cataract, he had about 624. Then we did a GAT with a phaco for him. And he had a IOP fluctuation. So this taught us that we shouldn't use too much of steroid after doing many of these procedures, because we opened up the channels, the outflow pathway is almost opened up. So if you use a lot of steroids, they do get a steroid response. How they get it, we don't know, because we have ripped open the channel, and that's again debatable. But I would also, since we don't do so much of experimental studies in our center, but I still, within the framework of this, I would like to imagine that even the outer wall of the Schramm's canal responds to steroid, not only the inner wall, which you would always presume. So there is a outer wall, inner wall is what we study more, as you would have seen the previous speaker, but the outer wall is studied less, which are there, the corrector channels. So that may also respond to steroids, so we don't know. But ultimately, he had to have one medication to control his intraocular pressure. So this gentleman is a juvenile open angle glaucoma or early POAG. He had a pressures of 26 millimeters of mercury, both eyes, on 3 medications. So the profession plays an important role. So if we were to do a glaucoma surgery for him, put mitomycin C, make a filtering bleb and filtering cicatric, he can never get into the water and do whatever he does. There's a very high chance of endophthalmitis. And also we prefer to do a GAT procedure for him. And this is how GAT is done. So you go into the chamber with a cohesive viscoelastic, and then you incise the trabecular meshwork, and you have a blunt-tipped suture, a 50 or a 60. So if it's a very advanced glaucoma patient, we would use, because the Schramm's canal will be narrowed down, so use a 60 proline suture. If it's a wider or an early presentation, you can use a 50 proline suture. And since I do canaloplasty also, I use both these sutures from the external side also. So if it's a very advanced pseudophakic glaucoma, I would use a 60. If it's a very early presentation, I would use a 50, because you can accommodate that big suture. So introduce the suture, and there's, of course, as you know, there's a lot of regurgitant blood, reflux blood, and then you have to do this multiple times and make sure the suture comes out on the opposite side. As you would notice, the suture, as it is coming out, it will push a blob of blood from the opposite side. So you keep looking at the opposite side of the entry. So you can see that the Schramm's canal gets filled with blood, and that the suture, which is blunt tipped, which is umbrella, will keep pushing the blood forward, because immediately after you induce hypotony, the Schramm's canal is filled with blood. So you look at the opposite side. As you see a blob of blood, that means the suture is coming closer and closer to you. So the suture tip, that is, so that you can know that you are almost 360 degrees. So you need to have about 25 to 26 strokes before you get the suture on the opposite side. So that's an indication that you are in the correct plane. So this is a very laborious process, and by the time we start the procedure, our staff will say, okay, sir, one of us is going for lunch. So it may take 5 minutes, it may take even longer than that, and that's how the process with GAT is. It's always every time you do it, it's always a learning curve. And because it's filled with heme, you have to again visualize it properly, and there you can see the tip of the suture on the opposite side. And make sure you identify it, and then you use a forceps. We use a VR surgery forceps for the internal one, which is available with our VR surgeons, and then you hold it and pull it out, and use a tying forceps on the opposite side. Reduce the magnification, remove the gonio lens, and then you could tear open the Schramm's canal. You can see that the eye is phakic. It's not a pseudophakic eye, it's a phakic eye, so this can be done comfortably in phakic eyes also. Many of our initial learning we did in phakic eyes. And they respond quite well. They do very well for almost 3 to 4 years without medication. We always do about 30 to 40% of viscoelastic, especially sodium hyaluronate, in the anterior chamber. One of the causes of one of the components which gets lost in progressive glaucoma is hyaluronic acid in the trabecular meshwork. That is one component. So we feel that if we were to leave it, it also allows the replacement of that substance in the, although artificial, leaves that substance in the Schlem's canal nearby area, and then that also helps to allow the percolation of the aqueous humor. Now, we don't test, as Dr. Aparna has shown. I still feel that what Dr. Mandal says, that not even entering the antechamber during TRAB is the way to go. So we don't test for the reflux. What I personally feel is that you may damage whatever remaining collector channels there are. So we just form the chamber with sodium hyalurate, and then just we leave it. You can also combine this with small incision cataract surgery. So this is after placing the intraocular lens. You could visualize, you can suture the port. The ports you can suture, and then you have a tight wound so that the hypotony doesn't occur, and then you could go ahead and do your, the only thing is you should do it temporally. So the SICS has to be temporally. You could also do it superiorly, but again you'll be, you could do that as well. But that defeats the purpose because you want to preserve the superior conjunctiva. So always better do SICS. So if you have a low pay patient, you can always do a SICS with a manual GAT with a SICS. So this is something which everybody has experienced, some of us experienced. You have heme behind the intraocular lens, and you be ready to, lyse the capsule very quickly. Within a month or so, you may have to, because the patient will be very uncomfortable. He's paid a lot of money to see well, and because of this, he'll have low vision. So you may be forced to do a YAG capsulotomy very early. Pseudo exfoliation glaucoma, you could do it topically also. This is a phaco-GAT procedure. Phaco has been done, and GAT procedure is ongoing, and you can see that every time you push the suture, the patient winces. So if you, here the important thing is you should not use the combination of tropicamide and phenylephrine all combo. I don't have any financial, something like the phenocaine or the litropamine you should not use, because you get a very fast Uret-Zavalia syndrome. The iris goes and sticks to the cut edge of the trabecular meshwork, and you get a mid-dilated pupil the very next day, and it's very difficult to reverse that. So don't use substances like phenocaine when you do a GAT procedure, because this is something which we have faced, and we have burnt our fingers with that. So of course this is topical. You could use intracameral lignocaine if you want to. I'll skip this. And the other things which don't usually work are, one is hamartomas. So nevus of aorta, viral keratitis, they don't work very well. Trabeculitis works very well. So if you have isolated trabeculitis, it's just best to do a GAT procedure. The other place where we have used is in Cruzon syndrome. This patient came to us with low vision, and we were able to rehabilitate him very well using a GAT, phaco-GAT procedure. I'll stop here. Thank you for patient listening.
Now, as we move on, we go to Dr. Devender, who will be presenting on the newer goniotomies, and as well as talk about the Tenito microhook, because that's being talked about a lot. So, Dr. Devender.
So good afternoon all, and thank you Aparna Madam, and thank you Scientific Committee for giving this opportunity. Today I'm going to talk about Tenito microhook and the newer goniotomy what is in pipeline. No financial disclosure. As all we know, whatever kind of goniotomy do, either sectoral or 120, or either you excise the trabecular meshwork for 360 degree. So once you reduce that the resistance toward the TM, definitely your IP is going to come down. But only problem is what the goniotomy we do previous time or the olden era, just we incise it. So, but the newer goniotomies, what we do, either doing KDB or Tenito or other goniotomy. So what we do, we elevate the TM, excise the part of the TM. And that's why there's no leaflet and there's a less chance of fibrosis. That is why we are getting the much better result with the newer goniotomy. So most commonly performed goniotomies are GAT, KDB, and BENG. Right now I'm talking about the newer goniotomies like Tenito, iVent, Aspilot, and gonioscurver. So in our center also we have changed a lot. We do a lot of MIGS in our center. Almost we do a trap very less. So coming to Tenito, it is a cylindrical Sinski kind of instrument. The instrument are coming in 3 types: straight right-handed, left-handed, and the straight one. So this is the only procedure in which you can incise the 120 to 180 to 220 to 240 degree apart from the GAT. So this is the instrument I'm showing in the surgical video. This is the right-hand side and left-hand side. So this is the right hand side, you can go the supronasal, and the left hand side you can go the infranasal size. So like the any other surgical procedure for MIGS, by seeing first of all you inflate your anterior chamber with high density viscoelastic, and this Tanito microhook is introduced into the TM, and you can nicely incising it. Once you incise, you can see the posterior wall of the Slem's canal. Once we completed the inferiorly, either you can complete inferiorly or superiorly, whatever you want to start. Once we complete the nasal angle, then you turn your microscope, you can shift to opposite side, and you can treat that temporal angle also. Only thing is required, this is a nasal angle in high magnification, and again this I am treating the temporal and inferior angle. Only thing, you need one extra side port when you're treating for the temporal angle. So at the end of the surgery, as the previous speaker shows, is nice aqueous veins filled with the trypan blue, and this is blanching. So we can understand if this is seeing such kind of blanching, you can predict your surgery probably is working well. Now coming to the another video, similar video, even the PXF glaucoma, you can consider, you can get the very good outcome, especially in goniotomies, especially tentomicrohab, excellent outcome in PXF glaucoma. So similar way in the PXF glaucoma, the outcome is so good, we are used to perform only on the nasal goniotomy. It doesn't touch the temporal angle. Just it's 120 to 180 degree is give the enough and sufficient result. Now move on to the another situation. Sometimes the glaucoma surgeon, we face the all difficult cases, and such kind of cases when you have the iris coloboma and your lens also not stable, AC is very shallow. In this situation, doing a trap really is very, very challenging. So in such situations, usually the Tanito, after completing the phaco surgery, place the lens, and you can perform the goniotomy so easily and simply. Really, such surgeries are very boon for such a difficult scenarios. And you can get the very good outcome, especially in these challenging cases. So this way. So this is we did one prospective randomized control trial where we did the two groups, where one is phaco Tanito group, another group is a phaco group. So 57 patients in each group. At the end of the 12 month, the phaco Tanito group IP reduced from 26 to 12, while in the phaco group 25 to 20. And the glaucoma medication reduced from 0.6 to 2. And really this is no major safety concern, only except few hypema we found in a phaco Tanito group. And similar outcome we find by the other study, have the 3-year follow-up, and we have this procedure very efficacious, easy to learn, economic, and having the very good safety profile. I am fortunate to meet the inventor of Tanito, this master Musket Tanito. I met him and learned from him. Now move into some neogoniotomy. So this is called absolute juxta canalicular space goniotomy. So this goniotomy, as we know, the minimum surgery, so minimum we want to do as minimum as damage to the TM. So this specially designed tissue, this foot plate is a tapering foot plate end. So in this procedure, good part is this, we are just entertaining only the 60 degree of the nasal goniotomy. So this, you can see this specialized instrument goes into the trabecular meshwork, stretch it, lift it, and keep it there. I'll show in video. This is the absolute goniotomy. You can see here the tapering in. This tapering in goes into the trabecular meshwork. So this is only thing is this instrument little bulky, so we have to move and slide it. Once you move into anterior chamber, just you are taking the TM, stretching it, keeping it, and this beauty of this part, we are not removing any TM. We scratch TM and put into there only. So this tissue, this TM tissue work as we bulldoze it. So this TM tissue is going to bridge the wall of the Slem's canal. So it's keep your goniotomy open. That's why it's a small incision, only 60 degree, going to give you the good outcome. Another videos. So this another video saying the same procedure. So just be going right now, starting from the inferior, going to the superior, scratching it, lifting it, and we are going to keep the tissue in their canal only. We are taking the tissue, but we are not taking out of the eye. Everything is there only. And sometimes this tissue is used to help in keep the open canal. And this is the outcome is published in Journal of Glaucoma. The 60 degree of goniotomy reduced the IOP 38% at 12 months, 35 at 18 months, and 31 is 24 months. Similar result, we compare the absolute goniotomy compared with the Bang, which is the most popular procedure in our country, and we find out the outcome are almost similar. But the interesting part we find out at the 6 months in the absolute group, the anti-glaucoma medication isn't required. So is compared to Bang, it is much superior. So coming to the new surgery is called the interventional valve enhancing glaucoma surgery. This is probably going to be one of the game changer in the MIGS, because it's a very, very new and very, very fascinating surgery. So what we do in this surgery, this is a valve enhancing MIGS. So it helps the IP reduce by aqueous outflow through the Slem's canal by optimizing the ciliary body and skull as per vector forces. So what we thought, there's a pulsatile outflow of the channel in the behind the trabecular meshwork and the Slem's canal. As madam was talking about how the uniaxial flow are there. Because flow are there because some valvular mechanism is there and the pulsatile flow through those valves. So what we do, when we do all the other MIGS, we are going to damage those channels. We are going to damage the outflow system hole. So what is doing in this surgery? We are making an incision above the salve line, and apart from that, we are not damaging the tissue at all by keeping the TM intact. So making the just vertical slit anterior to the Slem's canal. So this is the video is invented by Dr. Grover. I am collaboratively working with Dr. Grover, and so we here we that this surgery is invented by Grover and presented in Glaucoma Surgical Day lecture in AGS, American Glaucoma Society Surgery meeting. It is a very prestigious lecture. So this is the video. You can see this procedure after completing the phacoemulsification. Just a minute. But you move over. Plate is going to the next slide automatically. Play it right now. Yeah, play in halfway. Yeah. So put the Swan-Jacob lens, and this is specialized spatula is called the I-bend spatula. It's specially designed. So this spatula here, you can see I'm working at the level of the Solway's line, just above the anterior trabecular meshwork. So in this procedure, I'm not going to harm the PTM. PTM going to be there, ATM going to be there. I'm just creating a small, fine line above near the Solway's line. And you can see at the end of the surgery, really we have the comparable outcome. We are having the comparable outcome to the GAT. But not the GAT, we don't get the such number, but our results are very good. You can see this dye in the veins, and it's showing the very good outcome. So if you see we have to prove it how it's working or not. So you do the OCT in such cases, see the pre-op OCT of this picture. Then you see this what the picture is shown by the madam. We find out the punch-out lesion in AIOS2025. You can see the creator. But unique part of this surgery, here you see this is a vertical slit kind of thing. So here we are not damaging the tissue. Tissue is remaining going to be there. You can see here nicely in the OCT picture, here just a vertical slit here. And they do this is the patient. One example is 6'9", IUP15 with the 2 medication. You can see the Slem's canal area in 0.032. After the surgery, the Slem's canal is going to widen, IUP become the 13, and amazing result. So now coming to the another surgery is called the gonio scrubber. These are some new surgery, still is not in the market, just an experimental phase. So this is the goniotomy in this, we don't remove the TM, just we scrape up or wash the TM. So how we wash this one specialized instrument is called the gonio scrubber. I'll show you after this scraper. The instrument is still in developmental phase. You can see this silicone rubber. You just be mob it or groom now. Just we groom it. So what we are doing in this procedure, just the trabecular meshwork, just we are grooming it. So what you're going to do, we are going to remove the extra metromatrix proteins and some dirt part of this like this way. Just we are grooming it. And this instrument has a very good outcome, especially in the pigmentary glaucoma. pigmentary and pseudo-exfoliation glaucoma. But we can't expect such surgery to give the very low IOP, but they moderately reduce the IOP. This way. Right. So another goniotomy in pipeline really is not available in India. It's available only in the Europe. It's called the AIOS, excimer laser trabeculostomy. In this, what we use the excimer laser to photoablate and create the hole into the trabecular meshwork. You can see the video. The excimer laser is used, and here this examiner, what they touch the trabecular meshwork, and just touching, they creating the hole. So this, through this hole, aqueous directly communicate into the Slem's canal. This is a newer procedure. A number of the holes you want to add, 1 to 10, depending upon the IB control you want. Really, this is just 24-month outcomes are available, single study. Maybe in future we get such more newer goniotomies. So the newer goniotomies promising the good implant-free with minimal trabecular damage, providing the good result. So probably the MIGS is a future of glaucoma surgery. Soon, about the 50 or 70% surgery should be the MIGS. The entrapment tube always key for the tough and challenging cases. This is my team. Thank you for kind attention.
Thank you, Dr. Devendra. So we are going to be really confused with in the coming years with more and more options coming up, and we'll be even confused as to what is going to work best. So coming to the last talk, Dr. Madhavi Pillai will be talking on gauging the MIGS and its role with swept source anterior segment OCT. Dr. Madhavi.
Thank you, Scientific Committee AIOS, and thank you, Aparna ma'am, and my mentor, Dr. Devendra Maheshwari sir, for giving me this opportunity. Good afternoon, one and all. Today, I'll be speaking on gauging mix with swept source AIOS-OCT. Now that we have seen quite a lot of minimally invasive glaucoma surgery procedures, we would like to know which of these procedures are really effective, and what are the structural changes that takes place after these MIGS, and what are going to be the long-term effects, and is there a way to assess it actually? So AIOS-OCT and AIOS-OCT angiography helps us to visualize the aqueous outflow pathways, angle anatomy, and we can also, in cases of device-based MIGS, we can see the implant placement and also look at the structural impact after the minimally invasive glaucoma surgery. So I have no financial disclosures, but most of the presentation I'll be showing images from CASIA 2, that is from Tomy, Japan. So these swept source AIOS-OCT gives high resolution images, and they have a faster scan speed and deeper penetration with a wide field view, and you can see a beautiful gonioscopic and three-dimensional view with this swept source AIOS-OCT. So this helps in preoperative patient selection and planning. Intraoperative, madam has already shown beautiful intraoperative OCT. I'll be concentrating on the postoperative effects of this swept source AIOS-OCT. So as I already said, in device-based MIGS, we can look for the placement of the devices like eye stent and hydrous stent, whether the devices are placed in the proper anatomical position. Here you can see the hydrous stent. So coming to the excisional based goniotomies, so we can look at the clefts in the excisional goniotomies, like in this case, the KDB goniotomy. So you can see a beautiful cleft in the clean cut and beautiful cleft in cases of KDB goniotomy. So these are the various sections actually moving along, you can see with the help of the swept source AIOS-OCT. So you can see how beautifully and clean cut the cleft is. So next, coming to the bend ab interno needle goniectomy. So here, if you compare with the KDB goniotomy, you can see the cleft is not as well defined as that with the Cahook dual blade goniotomy. So this proves that the KDB goniotomy, which is specially designed for that purpose, while the bend ab interno needle goniectomy is not designed for the purpose, so the cleft may not be as well defined as with the KDB goniotomy. But we don't know how the impact on IOP is going to be. So this is how the structure at the angle anatomy looks like. So with Tanito microhook trabeculotomy, so now we talked about the excisional procedure, while Tanito microhook trabeculotomy is actually a cleavage procedure which cleaves the trabecular meshwork and the inner wall of the Schlemm's canal. So let's have a look how the AIOS-OCT looks like in Tanito microhook trabeculotomy. So here you can see, compared to the clefts of the KDB goniotomy and the bang, here you can see a thin cleft, thin and narrow cleft. So this is actually an incisional procedure rather than an excisional procedure. So once again, while moving through the sessions in the nasal angle, here you can see the cleft of the tenito microhook trabeculotomy. So this again is the how it looks so beautiful in the three-dimensional view of the tenito microhook trabeculotomy. You can see the cleft here in the 3D view. So when it comes to GAT, we know that it is a 360-degree trabeculotomy. So post GAT, you can see both the nasal as well as the temporal angles. There is a beautiful cleft. Once again, this is how the 360-degree view looks like in a three-dimensional aspect of the Swepso's ASOCT. So moving through the sections, you can have how the cleft looks like in each section, in each angle, nasal as well as temporal. So this is how the objectively we are looking at qualitative analysis of the ASOCT. So this is one particular case in which GAT was done in a case of post-RD. So while moving through the section, you can see the tube here, and you can, as well as the same section, you can see the cleft also of the GAT cleft also see. So this is another aspect of the Swepso's ASOCT using CASIA, which uses the star 360 degree. So in the same section, we can see the clefts in multiple sections, and here you can see a blood clot in the inferior angle and in the 300 angle. So now that we have seen the different types of clefts, we can also assess the scarring post minimally invasive glaucoma surgery, and here you can see the scarred cleft. So in this particular case, the GAT leaflet has actually closed after surgery. This is 1 month post-op in which the leaflet has closed after the surgery. So now that we have seen how we can qualitatively assess, now we can also do a quantitative assessment using CASIA. So we can assess the angle parameters pre-operatively using this star 360 degree again, using the 2D assessment, 2D analysis. Sorry. So the angle parameters can be measured pre-operatively. And after post-phaco and GSL, you can clearly see the opening of the angle. So this is another index also, that is called the ITC index, the iridotrabecular contact index, which actually predicts the angle closure. So this ITC index can also be used before and after surgery to show that there is enough opening of the angle. So here you can see the pars areas post-surgery. Again here you can clearly see post-op ASOCT showing the ITC index in the green. So this shows that the angle has completely opened up post-goniosynovial lysis. So another way of assessing using ASOCT is the measurement of the Schlemm's canal area. So sir had previously shown in the case of eye vent. So I'll just show how to measure this using the ASOCT. So you have to select a session where the Schlemm's canal is clearly visible. And then using the same machine, you can mark the borders of the Schlemm's canal, and the machine will automatically calculate the area and the circumference of the Schlemm's canal. So this can be utilized for pre-op assessment as well as the post-op assessment, and see the changes in the Schlemm's canal area and the circumference, how beautifully it has increased after the minimally invasive glaucoma surgery. So this may be one way to assess the impact of MIGS pre and post surgery. So another thing that we can do is measuring the length of the cleft. So how is the cleft, whether the cleft is closed, whether the cleft is scarred, all these things can be well and clearly seen with the high definition Swepso's ASOCT. So there is a meta-analysis which included multiple studies, so 8 out of 21 studies with Zen, Trabectome, iStent Inject, KDB. So majority of the studies used ASOCT, and they have shown that ASOCT can be used to objectively determine changes in the anterior chamber angle anatomy. So this is one paper by Aparna Rao ma'am. She was actually showing previously how the scarring response varies with GAT and MIT. And one interesting point that I noted was the severe scarring in the form of a trench pattern, which seemed to predict the need for medications for IOP control. However, they independently did not influence the IOP final or the surgical outcome. So we don't know whether these structural changes are actually going to correlate with the intraocular pressure is something we don't know yet. Another thing that is coming up is the OCT angiography. So AIOS-OCT angiography can be used to look at the images of the sclera and the conjunctiva at the nasal and the corneal limbus. So this particular study interestingly shows there is a reduction in the deep vessel density. So this is the preoperative image. If you see the post-op image, there is a reduction in the vessel density, and this was shown to be directly associated with the intraocular pressure reduction. So to summarize, with so many mixed procedures in the block, we need to assess the MIGS objectively as well. And AIOS-OCT using swept source can help in pre-op evaluation, intra-op assessment, as well as post-operative monitoring. However, the future direction should aim at standardizing the AIOS-OCT protocols. Right now, we don't have any standardized protocols, so we need to standardize these protocols specifically for minimally invasive glaucoma surgery outcomes. I would like to thank my mentor and my academic team. Thank you.
Thank you, Madhvi, for illustrative lecture. Yeah, madam, you want to say something? So I think there will be a lack of time. If you have any question, you can just talk personally. Thank you all.